It's been a long day, so I'm glad you're still here. How many of us have CML? So the rest are family. How many of us are on Gleevec, imatinib? A majority. How many on nilotinib, Tasigna? Okay, a few. The satinib? Oh, very good. Bosutinib? Ponatinib? So there are a lot of INIBs. So today we are going to discuss some of the INIBs because we thought that, now that we've got at least 5 INIBs, 3 are already registered, 1 is going to register soon, 1 possibly may or may not register depending on the safety issues, and there are more to come. So these INIBs are called TKI. Have you heard of TKI or not? You haven't heard of TKI? Tak tahu apa itu TKI. TKI adalah a class of drugs. Dan ini INIBs semua adalah TKIs. TKI stand for tyrosine kinase inhibitor. Jadi ubat ini adalah untuk inhibit tyrosine kinase. Tyrosine kinase. Dan tyrosine kinase ini memang adalah satu protein. It's a protein that is found in our cells. And when the tyrosine kinase is dysregulated or not controlled, our cells just keep on proliferating or making a lot. And that's why we get CML. So in CML, our tyrosine kinase is not regulated. So it becomes uncontrolled. Because of the uncontrolled nature of the tyrosine kinase, itu tyrosine kinase kita semua pun memang ada. But when it's uncontrolled, we make too much cells. And so we get chronic myeloid leukemia. All right, so the type of tyrosine kinase that our CML cells make is called the ABL or able tyrosine kinase. Alright, and this group of drugs, ubat yang kita ambil untuk control ini disease adalah untuk inhibit ini tyrosine kinase. So the first tyrosine kinase, so in short we always call TKIs. So the first TKI yang kita temui is really Gleevec lah. So Gleevec is really the forefront sebab dalam CML memang Gleevec ini berkesan. Its effect is to inhibit ataupun menentang itu ABL punya tyrosine kinase. Alright. So it was studied in the late 90s, and then really in 2001 it was first registered. And I think somewhere in 2003 we started using the drug already in Malaysia. Okay, so it was quite rapid. And so up to now in 2014, kita memang sudah ada banyak pengalaman. A lot of experience with imatinib. We know that in 60% of our CML patients is very effective. Unfortunately, dalam 30 atau 40% orang, it is not so effective. Why? Because some of it has some side effects. We can't tolerate the drug. Some of our CMLs just don't respond to Gleevec, all right, through many other mechanisms. But overall, 60% of patients live very long, all right? Because it is the first INIB, it is not so powerful compared to the later INIBs. It's like your Proton saga, isn't it? Every year you get a more powerful engine. So they make changes to the engine. And so, the car is better, it runs faster. But may not always be as good as the first. The first generation Proton saga is still very good, isn't it? Still very reliable, isn't it? And then the later ones are not so reliable. The windows always don't work, right? So although we have a more powerful engine, but the car doesn't work as well. There are little niggly defects in the second or third generation. So although it's more powerful, it is not necessarily always the best. But anyway, imatinib or Gleevec is available in Malaysia sebagai first line. And we know a lot of side effects about Gleevec lah. Ini memang kita dah banyak pengalaman dengan Gleevec. I think some of the main side effects are nausea. Some of us take it, we don't feel well. Some of us get swelling. Early in the morning, you may get swelling over your eyes or swelling of the legs, and those are just really fluid retention. Somehow taking Gleevec, we retain fluid, all right? But it's not a sign that we're having kidney failure or anything, or liver failure. It just means that we just retain a bit more fluid. Some of us have cramps. Sometimes these cramps can happen at night. Sometimes can happen at any time of the day, all right? It can be in our legs, or it can be in our hands, or in our fingers, or sometimes in our back. Sometimes it's very disabling, very mengganggu kita, especially when we sleep. But most times it is not too problematic. And most of us may be able to get away with like taking some calcium supplements, some magnesium supplements, some oral rehydration salts, macam 100 plus, and some of your drinks. Or some of us will just keep warm and, you know, try some massage therapy at night. So most patients are not very problematic. Some side effects we don't like our skin get very light, like our SK2 effect. So some people like it very much because they look like they are, you know, taking SK2. Some don't like it because they have cause of the hyperpigmentation. All right, so, but usually that is not a dangerous side effect, although you know that you have to protect yourself from sun because it's too much sun exposure. All right, so always remember to wear your sunscreen. Some patients have got a little bit of diarrhea. One of the problems with Gleevec after taking long term is really weight gain. And we don't know why there is a weight gain. It could be that because now that we are getting very well, we tend to put on weight. Although we don't eat a lot, we still put on a lot of weight. All right, it's a sign that we are getting well. But you know that too much weight gain is also not good for you because when you have too much weight gain, you know, then you get other problems, isn't it? Then you get things like cholesterol, hypertension, you get bone problems, bone pains. So you have to be careful of your diet. You have to control, stick to 1,000 kilocalories, eat colorful food at the buffet, you know, just stick to vegetables, don't take the meat. So try to cut down on your diet, do more activity. Make sure that, you know, if you have a rich meal, you do more activity, all right? So, but by and large, I think most of the side effects that you hear about kesan sampingannya bukan serious lah. Walaupun dia memang ada impact dalam quality of life kita. Memang quality of life kita sikit kurang baik kalau banding dengan orang biasa, tapi dia bukanlah satu jenis kesan sampingan atau side effect yang dangerous ataupun membahayakan kita. For a long time, we worry whether Gleevec will cause liver failure because during the masa peringkat permulaan, during the initial phase, there were some people who died of liver failure. But then, you know, after 13 years of experience, we found that that is not true. Most of the initial cases were those patients who were taking other medicines, so supplements or painkillers. And then we were also worried, very worried that, you know, patients on Gleevec will get heart disease because again, there were some patients who got heart problems. But again, that did not work out. You know, we have now 13 years experience and really there is not much more heart disease than in the normal population. But those people who already have heart disease, when you take Gleevec, your heart function may come down a little bit. So you have to be very careful when you're taking Gleevec if already you have heart disease. All right, but Gleevec does not result in heart disease. But the other thing that we were worried about whether Gleevec causes cancer. In the long run, if you take Gleevec for such a long time, will you get new cancers, other cancers like skin cancer, lung cancer? But after looking at the data for so many years now, actually there's none, all right? So Gleevec dalam jangka masa panjang is a very safe drug to take. There will always be this, what we call acute side effects or short-term side effects that you just have to learn how to manage well, how to prevent nausea, how to prevent diarrhea, how to prevent cramps, what to do when you have cramps, how to deal with fluid retention, weight gain, all right? Those are the things that you really have to tackle. If you're able to tackle well, you are able to live a good life, a long life with Gleevec. And really it is currently the safest TKI or the safest inhib that we have. Then you have Tasigna. So about 6 years later, Tasigna came on. Tasigna was registered in 2007, which is 6 years after Gleevec. And Tasigna came from the same company, which is known as Novartis. Novartis went back to the lab and did some modifications to the molecule. And it is about 30 to 40 times more powerful against the ABL tyrosine kinase. All right, so it's a more powerful inhib than Gleevec. And if you were to compare against Gleevec, say if upfront we were to take it, it will be effective in 80 to 90% of patients. So when we say Gleevec is 60%, imatinib, Tasigna would be slightly more effective, about 10 to 20% more effective. So if I were to treat 10 patients like you, 6 of you will respond very well with Gleevec. But if I were to treat you with Tasigna, 8 of you will respond very well. That means 2 more will respond very well. That means that if I treat all of you with Gleevec, 4 of you out of the 10 may have to change to something else. So you may have to change to a second line. So Tasigna covers more patients and it is more effective. It is also approved for both first and second line, but the side effects is just slightly different compared to Gleevec. Usually when you first start Tasigna, you may get a severe headache. That is usually very temporary. The first 2 weeks you get very bad headache and very bad muscle pain and cramps, But generally after a while it just disappears. But the main side effect that a lot of patients don't like about Tasigna is skin rash. Gleevec also you get skin rash, but Tasigna you tend to get more skin rash, all right? So the skin becomes very dark, it's very itchy, and it becomes very dry. That sometimes is a problem for some of our patients on long-term Tasigna. The only worry about Tasigna at the moment, we only have about 6 years experience with Tasigna. So Gleevec, we already have 13 years experience, all right? So we know that Gleevec is quite safe for a long time, more than 10 years. Tasigna, we have only about 6 years experience. So it is effective, it is overall very safe, but in the 6 years or 7 years, we have begun to see patients with diabetes, all right? And we have also seen patients with what we call vascular diseases, meaning that there are some people who have had heart attacks and some people who have had strokes. And this may or may not have been related to Tasigna. And some patients have got severe abdominal pain that is related to pancreatitis, but that is quite rare. So it is a very good drug for CML. And it depends on your age, for instance, if you are an older person, perhaps you may be better to try Gleevec first and see, if Gleevec doesn't work, then only you switch to Tasigna. Because in those subset of patients, maybe your incidence of getting diabetes may be higher. Your incidence of getting heart disease may be slightly higher, all right? So, but it is still very safe, but there are some side effects that we have to manage on the long run, all right? Because we know that it may happen. The third drug that is available at the moment is known as dasatinib. One of you is on dasatinib. It also has 7 years experience. It is definitely more powerful than Gleevec and probably just as powerful as nilotinib, if not slightly more powerful than nilotinib. It's also effective in 80%. Tasigna, the problem with dasatinib or Sprycel at the moment is that it is distributed by a company known as Bristol Myers Squibb. And I think for many years now, because of the logistics in this region, Bristol Myers Squibb decided not to have a main office in Malaysia. So they closed their main office, and I think they operated in Singapore and from other countries. And because of that, there was no local distributor for dasatinib. So some of our patients had to get dasatinib through direct import from UK. They employ an intermediary or a distributor from which, they distributed dasatinib. Initially, they were giving it as a patient access where you get it free, and subsequently, patients have to buy. This year onwards, BMS is again going to reopen their office. So they're now exploring again the role of dasatinib or Sprycel in the country. They have not come back to me with what the pricing is likely going to be like, but probably it will be priced something like nilotinib or Tasigna, all right? And it's also approved for first and second line. Again, it is a fairly tolerable drug. The only problem is that if Gleevec causes a little bit of fluid retention, Sprycel causes a little bit more fluid retention. And this fluid retention can sometimes happen in the lungs or sometimes happen in the abdomen. So, and when it happens in the lungs, it may cause difficulty breathing, but that can be sorted out by taking it out and taking some diuretics or Lasix to get rid of the fluid. And that occurs in 20 to 30%. But there were a small subset of patients who had lung complications where they got high blood pressure inside the lungs, what we call pulmonary hypertension, all right? So if you are on Sprycel, you need to be monitored, right, to make sure that you don't develop these complications. So if you are to compare the three drugs that is already available in Malaysia and for sale or in the private or in the public, if you compare, you look at what we call cytogenetic response. In those early days, when we didn't have a better monitor, we always take your bone marrow to look at your chromosomes to see whether you can get a cytogenetic response or not. So the cytogenetic response is about 60 to 70%, about 10 to 20% better in nilotinib, and 10 to 20% better in dasatinib. When we started doing PCR, today we are doing PCR, so we don't have to do cytogenetic response anymore. So nowadays, most of us will take your blood and test it for PCR, all right? And if you were to, we look at two targets. One is what we call major molecular response, where your PCR comes back as 0.1%. So major molecular response is a response that is deeper than cytogenetic response. Dia adalah response yang lebih baik kalau banding dengan cytogenetic response, alright? That is what we call major molecular response. Dan kalau kita buat PCR, selalunya nombor dia adalah 0.1%, alright? If you can achieve 0.1% on your PCR, that means you're already very good response, even better than cytogenetic response. But you know, investigators are not happy. We want to get what we call complete molecular response, whereby di mana you tak boleh kesan pun sikit. That means your PCR is very, very close to zero. Not exactly zero, but very, very close to zero. That means it's very hard to detect any CML inside your blood. All right, that is what we call complete molecular response. And if you're taking nilotinib or dasatinib, about 20 to 25% of people may be able to achieve what we call complete molecular response. But if you're taking imatinib, likely it's going to be 10%, all right, with molecular response. But if you look at the survival all these years, we take away the response, all right? We're not interested in the response. We want to see how many people are surviving today. They are the same, all right? If you're taking imatinib, 95% are surviving. If you're taking nilotinib, 95%. So there is no difference in overall survival. And what does this happen? It is because they are the 10 or 20% who are not responding to imatinib, they get switched to nilotinib. So they still continue to survive, but they just change to another medicine. So that's why whether you start on nilotinib first, or you start on imatinib first, or you start on dasatinib first, likely your survival is the same. Although your responses may be slightly different. Some may be 10% less, but because we are monitoring you, we change you to something if you're not responding so well. And I think that is important. In terms of short-term side effects, maybe imatinib has a little bit more compared to nilotinib and dasatinib. But on the long term, because imatinib, we have longest follow-up. So we know long-term imatinib or Gleevec is quite safe, all right? For Tasigna or nilotinib, we are still not very sure. We still have to wait, all right, a few more years to 10 years or 15 years to see whether or not this diabetes or these vascular events or vascular disease is significant or not. Same as for the dasatinib, we have to wait longer and see really, is there many people developing high blood pressure inside the lungs, or is it just during the initial phase that we see? Just like when I say, initially when we were doing Gleevec, we thought we saw patients with heart failure, but later on, after 10 years, 15 years, we really didn't see it. It was not really that significant. So maybe they are too short in their follow-up. Kalau kita tunggu lama lagi, mungkin kita akan menjadi lebih jelas lah. But of course, the price, if Gleevec is the price of a BMW, nilotinib will be the price of a Porsche, and then the dasatinib is likely going to be the price of a Porsche or a Rolls Royce also. So all three are equally expensive lah. So we can only drive Proton Saga, so But I think at the moment, if you were to ask me, all three drugs would be almost equally the same, all right? There are two new drugs that I want to introduce to you. So apart from these three INIPs or these three TKIs, there are two more DKIs now. So for those of you who are not responding to imatinib, usually you will be switched to either nilotinib or dasatinib. And if you're not responding to either nilotinib or dasatinib, you may be switched to another inhib. This is what we call the second generation inhibs, all right? One is bosutinib and one is ponatinib. Bosutinib is made by Pfizer, a company known as Pfizer. It is just as powerful as Tasigna, and the response is going to be the same as Tasigna lah. Tapi kesan sampingan dia pun pada short term pun banyak. Dari segi gastric, jadi vomiting, diarrhea is quite common, stomach pain, and low blood counts lah. It is not registered yet, but we have already a few patients on bosutinib. The other drug, the fifth drug, is called ponatinib. Some patients with CML, mereka ada satu jenis mutation atau mutant strain of CML, because kalau kita makan ubat, the CML can mutate, all right? And very rarely they mutate. And there is one mutant strain known as the T315I that is the most dangerous mutation, all right? Because this T315I does not respond to any ubat at all, any of the known inhibs, all right? So sometimes when you are not responding to imatinib, or when you're not responding to nilotinib or dasatinib, your doctor may take a blood test and send it somewhere else, maybe to Singapore or to IMR or to UMMC to see your mutation, all right? Basically, what they want to see is whether you have this T315I, all right? And currently, at the moment, there's only one inhib that works, which is known as ponatinib, okay? It was available as a clinical trial a few years ago in Singapore, our nearest neighbor. The problem is that the patients who were taking ponatinib, there was a report of heart disease, heart problems. So FDA or the United States temporarily has deregistered ponatinib, okay, because of these safety concerns. So it is, while we always want a more powerful engine, it is not always clear whether a powerful engine is a safer engine, all right? The more powerful it is, we may run into an accident. So it's not always the more powerful, it is a better car. All right, sometimes a slower car may be just as good because it is safer. So ponatinib initially was a very powerful drug, very effective for T315I. When during the trial, unfortunately, we had to suspend. So every patient who remained on ponatinib, we have to weigh the benefit and the risk. Just now you saw the pharmacist. Every drug has got its side effects, all right? So if you have this T315I, but you have no other choice, then no choice, you have to take this drug. But if you didn't have this T315I, you have other choices, it is better you switch to other drugs. So they only limit to those people who are only responding to this, all right? And they are not adding any more patients while we are waiting for more safety reports. So it's currently not registered, and I don't think it will be registered anytime soon. So we talk a lot about inhibs, all right? We talk about Ferraris, we talk about Porsche, we talk about BMWs, all right? There's still the good old proton saga that you know that is available, all right? And this old proton saga is known as a bone marrow transplant or a stem cell transplant. Today, for CML, a stem cell transplant is not recommended anymore because there are so many effective agents that are available. But you see, the effective agents are available only when you can afford it, all right? It is not like the effective agents are like $1,000 a month. So the effective agents are $10,000 a month. Some of them are $16,000 a month. And you have to take it for a long term. So sometimes you also have to not forget your proton saga, your good old proton saga that is always there, has a sideline. And you know, stem cell transplant currently is the only therapy that is known to cure CML. No other treatment at the moment has been shown to cure CML. When I say cure CML, that means for a long time you have no CML if you successfully undergo a stem cell transplant. But transplant has its own risk, all right? There's a chance that if you do a transplant, you may die within the first 3 months or first 6 months because of the bone marrow transplant complications. So there's always a risk that you need to undertake when you're doing a bone marrow transplant. But over the years, the transplantation is getting safer and safer. We are doing older and older patients, so 60 years old, 65 years, we are still doing bone marrow transplants for them. And we used to do bone marrow transplants for only matched donors, meaning that you have a brother or sister who is matched. Now we can also do transplants for those with a donor not related to us, but also matched. But we are also doing donors whereby they are half matched. That means getting from our parents or getting from our brother and sister who is only half matched, what we call haplotransplants. Those are very new transplants that are currently being done even in our own center. So, it has been shown to be relatively safe and effective. But when I say safe, I don't mean 100% safe. When I say safe, there is still a 10 to 20% risk that you need to undertake. So if you ask the world's experts today, if you ask all the patients with CML, none of the CML patients will get a stem cell transplant upfront, all right? If you had CML, you should go on some inhib or TKI first. That is without a doubt. But CML has got 3 phases, the first phase, second phase, and third phase. The second and third phase is not likely to respond so well to an inhib. All right, if they respond, the response is going to be poor or shorter lived. So if you have you started off with a second or third phase, especially if you started off with a third phase or what we call the blast phase of CML, you should always consider a stem cell transplant, all right? Even if you respond well to an inhib or TKI. Or if you already have 1 cycle of TKI, you failed Gleevec already, you are failing bosutinib, you can go on to more and more inhibs. But the more inhibs you go on to, your response is going to be less and less and less. You should still always consider a stem cell transplant as an alternative. And those with the T315I mutation should get a transplant because today we don't have effective treatments. The only possible effective treatment can come with some major side effects like heart problem. And lastly is for our young patients, those of you who have children with CML, who are adolescents, teenagers with CMLs, young adults, they have difficulty adhering to their medications. It's very hard to get them to take medicines every day for the rest of their lives. And we have that in our own experience. All our students who are CML, they don't respond so well because they just have difficulty taking medicines. They all want to be like their friends. They want to be normal. They don't want to be patients. So they don't want to take medicines, all right? So stem cell transplant is something that we should not use as the first line, but we should also not forget it because it is a friend sometimes when we need it, okay? So often we get patients come to us and say, "Doctor, which TKI? Should I buy a BMW? Should I buy a Ferrari? Or should I buy a Proton Saga?" So how do we decide? How do we decide?
Depends on whether you have money or not.
Yeah, first of all, depends on how much money you have. So you open your bank book, you see, if I've got lots of money, I will buy a Ferrari, isn't it? Or if I have less money, I buy a Proton Saga, all right? So that is the easiest answer. Of course, all of us want to drive a Ferrari, right? If we have the chance. We like to drive a Ferrari. Every one of us would like to drive a bigger car, a BMW. So, but as I said, all 3 drugs are available in the formulary in Malaysia at the moment. Basically, the satinib likely will also come back in. But there are certain points that can help you decide. What you need to do is really to have a frank discussion with your doctor. The most important thing is to ask yourself, is my CML the sort of high-risk CML? All right. There are various scores that are available now. If you Google CML, what are the risk scores? Some people do what we call a Sokal risk score. Some people do what a UTOS risk score. Based on your blood counts, based on your spleen size, and so forth, they're able to calculate the score. And from the score, your doctor should be able to know whether you are low risk, intermediate risk, or high risk. All right. So if you're high risk, then you should get a Ferrari lah. If you got a low risk, then depends, all right? You can get either way, all right? Either will also respond so well. Why? Because if you had a high-risk CML, your chance of responding to the lower drug is less than if you respond to because you want the first response to be the best response, all right? So that will be the first thing that will help you. Secondly is that, do I have any medical problems? If I'm a smoker, I've got lung problem, I would avoid the dasatinib. If I'm already 50 years old, I got diabetes, I got high blood pressure, I would avoid the signal because I don't want to bring on more complications to my medical problems, isn't it? So it depends also whether you are totally fit or whether you have any heart problems. The third is, of course, whether I can pay, how much my insurance, or what is available in the KKM formulary. All right, and then the other thing is that if I start one, when do I switch? That means you need monitoring. How do I monitor? When is the time to switch? All right, these are issues that you need to tease out and talk to your physician, all right, at the start of the therapy. And your physician usually, or your doctor, will make the best choice for you, all right, depending on the condition that you have. So some of us who have patients with heart disease, generally we don't like to put them on the dasatinib or nilotinib. Then we try to use them a low dose imatinib, for instance. If I'm already on imatinib, should I then switch today, knowing that, nilotinib is even more powerful, or the dasatinib may be available? Should I switch to another inib, or should I just continue on my imatinib? What do you think? You want to switch or you don't want to switch? Huh? You want to stay? Should I switch or should I not switch? So that is the question. Now that there is one that is new, is available, do I want the more powerful one? All right, so there are a few things here. There are a few things that you need to ask your doctor. What is my current response? Is my response as good as I expect it to be? Have I achieved what we call MMR? Have you done a PCR? Have I achieved the 0.1% already? All right. If I've achieved my time points and you are happy, then there's no reason to switch. Why would you want to switch on to another medicine just because someone says it is 30 times more powerful or 20%? Because you already have achieved what you want to achieve, all right? The survival is the same, okay? So, but if you're not getting the response, what can I do to do the response? Should I increase my current drugs or should I switch? That one is something that you really need to talk to your doctor. The second thing is that, have you got any side effects from your current TKI? That may be another reason to switch. Some patients just cannot tolerate Gleevec. Every day they wake up, they just get nausea. They just feel like vomiting. They look at the drug they don't want to take, all right? So they just feel miserable with their Gleevec, all right? If that is the case, you need to switch, all right? So most of the minor side effects, we are able to adjust, or we are able to make better. But sometimes, no matter how we try, we just cannot make our side effects better. And because our side effects are there, we start skipping medicine. We skip medicines because of side effects. That's the time when you have to decide, maybe I should try another medicine, all right, that has less side effects. That is one. Of course, the third thing is whether it's available in your hospital or whether you can afford it. And fourth thing is, of course, whether they are safe. And I think the safety issue, all three are fairly safe, but the other two may need a bit of longer experience, all right, to tell us whether it is truly safe. Some of our patients say, can I stop? I've been taking Gleevec now for 5 years, 7 years. Can I stop my medicine now? My blood counts are so nice. Every time I come to the doctor, it looks good. All right, can I stop my medicines? So I would say not at the moment. It should be done only in an experiment or clinical trials, and there are a lot of clinical trials going. We ourselves also starting on a new trial. It must be done in the context of a trial, all right? That means in the context of a well-controlled experiment where we make sure that you've already got a very good response. The good response is what we call CMR, complete molecular response. You've been persistently getting a complete molecular response for a certain period of time, then you may ask your doctor, have you got a trial or have you got an experiment going on where we stop, and once you stop, we monitor you closely. That means every month you come and take blood and we check your PCR. Currently, as far as we know, those people who already have had a good response to Gleevec for at least 2 years, that means for 2 years, they have undetectable PCR. When they stop, about 40 to 50% of them actually need not take Gleevec for up to 2-3 years, all right? So, whether it's longer or not, we are not sure because these experiments just started. at least half of the patients looked like they might be able to stop. The other half, the PCR came up again, in which case when they retake the Gleevec, it went back to normal, all right? So it looks like we may be able to deal with it or consider what we call a drug holiday, all right, without having the medication for 2 years, 3 years, 4 years, but not at the moment outside of an experiment, all right? It must be done in a very carefully monitored experiment. And that is one reason why some people suggest for new patients with CML, maybe we try to get them on nilotinib so that they can get a bigger response, so that there's more chance of them stopping. But for those people on Gleevec, it is also seen that after a few years of Gleevec, if you get a good response, you can also consider that, all right? So you don't have to worry that you might miss. So you've heard from our pharmacists, you should take Gleevec with a meal and a large glass of water, all right? So Gleevec can be taken either once a day or twice a day, depending on your preference, all right? Try to take it at a regular time and try to space it about 12 hours. We have to avoid grapefruit because grapefruit increases the toxicity of the drug, all right? We don't often eat grapefruit, but if you come to Concord, sometimes you can get grapefruit. So in the hotel, for breakfast, you sometimes get grapefruit. It is very red in color. I think the closest is what we call the star fruit, our closest family, so you should also avoid the star fruit, all right? Nilotinib, unfortunately, cannot be taken once a day. It has to be taken twice a day, all right? Gleevec can be taken once a day, but nilotinib has to be taken twice a day. And unlike Gleevec, Gleevec is taken on with a full stomach. Nilotinib should not be taken with food. Because if you take nilotinib with food, it gets more absorbed and you get more toxicity. So you try to take nilotinib on an empty stomach. So usually we will say that, you take nilotinib first 2 hours and then only you start eating, all right, so that you have an empty stomach. But if you've already eaten, you should wait at least 1 hour for the digestion to take place first before you take your nilotinib. So at 2 hours, it's the other way around. That means if you have eaten, wait for 2 hours first, all right? So let the food digest before you eat it, or wait 1 hour before eating food, all right? Again, the same thing, avoid grapefruit, and you need to check your potassium and magnesium levels and ECG, because as I mentioned, there may be some heart problems with nilotinib. So the most important before I close is what we call compliance and adherence, all right? Compliance means we comply to our medication as well as our medical advice. That means, you come regularly, you check your blood, you follow instructions. That is compliance, all right? Adherence is adhering to the way that we take medicine, all right? The diet, the timing, the follow-up. That is very important, all right? So you need to ask yourself, how compliant or how adherent you are. Because this is a study that was done in UK, where they look at their patients with CML. And when they look at the patients with adherence, more than 90%, the chance of them getting a MMR or major molecular response is 90%. But if for those people whereby the adherence is less than 90%, the chance of getting their MMR is only 10%. That means if you adhere to your advice, you comply to your advice, the chance of you getting a good response is much higher than if you don't comply. So try to comply or comply, don't skip medications. Make sure you have some way of remembering when to take. Don't forget your medications, all right? Come for your follow-ups, do your checkups.
2 questions. One question is that, let's say, we have been under imatinib and we have achieved very good results, okay? And what happens, because our doctors advise and tell us that we must continue our medication, and there can be chances of a reversal. My question is that if in spite of continuing the medication and finally reach a good result of 0.1 of theirs, if there is a reversal, will this occurrence come, will it start in the same thing? Will it come in initial stage, or immediately it will come to the second stage or third stage? You know, is it the same cycle, or does it can come back and suddenly, you know, put us in a second stage level if there is a reversal?
So,
That's my first question.
so maybe if I answer your first question first, when you first start Gleevec, there is always a small chance that you will get what we call progression or very rapid reversal. All right, that usually happens during the first year. All right, so that means while you're taking Gleevec, if you started getting a CML at the first phase or what we call chronic phase, and you've started Gleevec, there's a small percentage of people that do develop into blast crisis or third phase suddenly while they're still taking Gleevec. All right, so that has been known to happen, but it is not very common. But for those patients who already have achieved what we call a major molecular response, for them to get this sort of sudden escape is not common. All right, it's not common. So you are fairly safe, but you can still lose response, meaning that, you know, if you are now 0.1 all the time, you may, you know, in a small percentage of people start climbing again to 0.2, to 1, and then to 2. So it's usually a very slow kind of response. That's why usually we monitor your PCR every 3 to 6 months. All right, as long as you've already achieved a very good response, 0.1, the chance of you escaping is still there, but it usually goes very slowly. And usually there is time for you to do other things, all right, to check for mutations or to increase your dose and so forth.
My second question is this: although you see, we are patients, especially me, from my experience, I am aware that I will have to take this for a long, long time. There are even young, you know, patients who complain. But I'm not complaining, but I want to ask this issue. For me, I don't miss the taking it daily, no. But because we are human beings, I tend sometimes to delay taking it punctually. Sometimes it's because we are occupied with work, or sometimes because we are tired. So our schedule will not always be punctual. And despite this, we still achieve major molecular change. But since just now, the previous doctor was telling us about the stages of drug effectiveness. So I would also like to ask this question: if we do not comply to the punctuality of our drugs, let's say 1 hour delay, 2 hours delay, to what extent is it, you know, permissible for us to forget to take it, you know, later? It must be at 2 or 3 times, or if it is too many times, it will affect our readings, and that how long? Because sometimes why I delay taking is that I noticed that long time taking imatinib, I still have the gas problem. You know, it doesn't go away. So I listen to my body, like some people said. If I get gas, I try not to take imatinib until the gas is gone. I eat something or try. Then I take it, because if even after food, after some time, sometimes gas remain. And if I take imatinib, the whole thing will come out. I mean it's a waste. It's a very expensive medicine. So we don't want to waste it by gurgitating the whole thing out. So that is why I'm not faithful to the punctuality. I admit that. But I don't miss the drug. Every day I take. So what will be the effect, doctor, if, you know, we do this? And how often can we procrastinate our time of taking the drug?
The best is not to procrastinate. The effect is usually very, not so much if you are taking a daily drug, like Gleevec, for instance, but the effect will be greater if a drug has to be taken twice a day. All right, so if you're supposed to take it 10 to 12 hours apart, then you sometimes take it 8 hours apart, or sometimes you take it 6 hours apart, or sometimes you take it even longer apart. So for those drugs that you are taking twice a day, the impact will be greater. The only problem is that when you start delaying, or when you start having different schedules, your tendency to forget or your tendency to miss those becomes even higher. All right, and that is the problem. So when you start having that, those are signals that, you know, eventually you may say, because today I'll take 2 hours later, then tomorrow I said, never mind lah, I said, let's just forget today and go tomorrow lah, you know, because you're already setting a different discipline and a different schedule for yourself. So I understand sometimes for Gleevec it is very difficult, and but it's important to keep to the timing, stick to a regular diet. And if you know that you are going to, this is the time about to take Gleevec, you somehow manage your life such that you don't get so much gas, or, you know, don't eat the foods that may create that kind of gas, you know, so such that you're able to take on time. It is human to forget, and I think, you know, you can, you know, take your house keys and then put it somewhere else, and then you totally forget where you've taken your key, because where you've put your key, because this is just part and parcel of daily life. So Gleevec is also part and parcel of your daily life. Sometimes you even forget whether you've taken it or you're not taken it, you know. So that's why we've always advised you to have some sort of a mechanism that is, you know, that works for you. Be it a calendar that is next to the your fridge, or where you keep your medications, or some SMS mechanism, or getting your caregiver to remind you, just to remind you, because sometimes you just forget. All right, so I would suggest that, you know, you stick to as close a schedule as possible. Try not to stray, you know, because the minute when you start straying, then you tell yourself, I still have got, you know, it's okay, because after a while you find that you skip 2 doses, you come back and check your blood, you see that it's still normal. Then after that it's okay, then the next time you skip 4 doses and you check your blood, it is still normal, and then you begin to skip more and more doses, and before you know it, your PCR starts climbing up. All right, so as I mentioned to you, you can begin to lose response slowly without knowing it. So it is not like you will quickly go back into 3rd phase. So that's the problem. Sometimes during the initial times when we were giving Gleevec, a lot of our patients thought, you know, I stopped Gleevec. The next time when I come to check, the counts are still okay, doctor didn't say anything. Then after that, 6 months later, you know, I come and check, the blood is still okay, I'm not taking my Gleevec, you know. But the problem is that the Gleevec, the response is so deep, you know, to what we call a molecular response, that for it to relapse may sometimes actually take months. And then sometimes by the time it starts relapsing, it's already too late for you. All right, so it is better that you just stick to a schedule.
My question is it true that Gleevec or imatinib has an impact for patient to conceive? And in the event after transplant, and after taking Gleevec for a few years, as advised by a doctor, and finally doctor said that you can stop taking Gleevec, will the chances of conceive be increased since you have stopped taking Gleevec?
So Gleevec has got an effect on the fetus and onto the sperm. So usually we recommend that while you are taking Gleevec, you don't conceive or don't get a baby. Gleevec, to my knowledge, doesn't really prevent people from conceiving. All right, so that is not a problem. The only problem is the transplant. When you undergo stem cell transplantation, you undergo very high dose chemotherapy or radiotherapy, and that dose of treatment can actually affect the ovaries or to the sperms. And a proportion of our patients then are not able to conceive because the ovary or the ovum is no longer active. It also depends on which age you are when you are doing the transplant. If the younger you are, you have a higher likelihood of recovery than the older you are when you are doing the transplant. So usually what we recommend is that, you know, you check with your gynecologist or obstetrics to check the hormone levels. So it depends on the stem cell transplantation. But still, while you're on Gleevec, don't conceive. Yes.
Hi, doctor. Can a patient go for holidays and lead a normal life, like overseas trip, all those?
It depends on whether you have money. If you have money, you can go on holiday. If you have no money, you can't go on holiday, right?
But
so if you spend all your money buying Gleevec, then, you know, there's no money, then you can't go on a holiday. So that is the problem. But the issue about CML and Gleevec is that it is to make you as close to a normal person or what you are as possible. So, you know, the whole idea of giving you Gleevec or giving an expensive treatment is not to make you a patient, isn't it? It's to make you back. And because of CML, you've got this tyrosine kinase that is too much or too abnormal, and we try to inhibit it. And by inhibiting it, we can almost bring you close to normal but not normal. When I say not normal, it means that you still have to come back for regular checkups, you still have to continue taking medicines, but you can be as close to normal as possible. So as long as you feel healthy, you feel fit, you can go overseas. Some of our patients actually go and do their courses in UK for 1 year, 2 years, you know, but they have to come back and somehow get their medication.
Okay, good. Thank you very much. Thank you.
Dato, as a mother caregiver, I know the window period is 6 months for the Gleevec. So I just have to like hope, love, and cheer that the Gleevec will work within the 6 months before what the PMR is
The
known,
CMR, yeah.
right? So, I mean, this is like, my daughter is in the 2nd month. Of course, as a mother, I'm very concerned that she will respond to the drug. And as I said, I just have to hope, love, and cheer that it works.
Yes.
And I have to be very positive, right?
Yes, you have to be very positive, but at the same time, don't be driven a lot by numbers, because whether we like it or not, there is a lot of influence from external that tells you what to do. Meaning that the companies that make drugs often try to influence, rightly or wrongly, how we should treat our patients. When I say that, they will tell you, for instance, you know, by 3 months you need to achieve a certain level, less than 10%. You know, so a lot of our patients get very upset when they don't achieve that level. But really, when you think about, if you take an antibiotic for a flu, some people respond in 3 days, some people respond in 5 days, some people respond in 7 days, some people need, you know, so we all have different levels of responses. There are what we call slow responders, meaning that we have had patients who achieve a major molecular response 3 years, 4 years down the line. They also get to quite a good curve, all right? They may be 1 or 2 percentage points less than someone who achieves it faster, all right? Of course, if you can achieve faster, the better, you know, because then, as I said, your chance of quickly progressing is less. Because as I said, during the first year, there sometimes may be a small risk, 1 to 2% that you may rapidly progress, but by and large, more than 90% they don't, all right? So if you don't achieve it, but you are still responding, you know, the targets, you know, don't get too upset. You can wait for another 3 months and then see. As long as your disease is slowly coming down, you may not be able to get 10 A's like everybody else, you know, but you are getting 7 A's, you know, you are still getting there, but you are just a slower response. As long as your disease is comfortable. Companies, of course, like you to do things, meaning that they want you to do certain things for certain reasons. Like many of the reasons are good reasons as well, but many of the reasons, of course, are to get you to switch to more expensive medications. You know, sometimes the license is expiring already, so they need to switch. There are various reasons, but I would say that, you know, there are some patients who really require to switch very rapidly. But there are also many patients of ours whereby they actually don't need to they don't need to switch as rapidly as we want, but they still slowly also get to where we want to get. All right. I'm sure she'll do well if she takes her medicine regularly.
Yeah, thank you. This is the, I said as a mom, motherly concern.
Yes, I'm sure.
Because she's young.
Yes.
And we just hope, love, and pray, and it's positive. Just journey with her.
Yes.
Thanks very much.
Thank you so much.
Yeah.
I would like to ask this question because I think a lot of people here are patients and they are looking for hope actually. Hope in the sense that as Doctor said, as Dato has said, mentioned just now, instead of being a patient, of course, everybody want to be normal. So we would like to be off of the medicine, of course, ultimately one day. So the issue is what Doctor, I think, has clearly explained. I think the major thing is to achieve complete molecular remission. What is the chances of achieving that? Is that possible? Is a lot of people will it achieve that, or will it achieve only major molecular remission? Because I also asked around, most of the people also achieve MMR instead of complete remission. So when we is that means that only we achieve complete remission, And for how long, then only we go for the trial?
In reality, most patients on Gleevec are able to achieve CMR in about 10%, 20%, 10 to 20%. For patients who are on nilotinib and dasatinib, the reality is only 30 to 40% are able to achieve a complete molecular response. And if you believe what I say, to say that roughly about 50% are able to stop without the disease recurring within the next 2 or 3 years, then it is likely that for patients on imatinib, it could be that 10% of you may be able to stop. And if you're on nilotinib, about 20% of you may be able to stop. That means out of every 10 patients who are on nilotinib, with what we know today, probably 2 persons may be able to stop for a period of time, and this could be 2 or 3 years. That is the reality at the moment. The thing is that this concept is a concept that is new, that is, just, upon us over the last 1 or 2 years. So it will affect how we want to treat CML in the future. When I say CML, I mean the subsequent new cases that came along, because if that is truly the case, then, for every patient, then we should at least try to get a CMR, all right? Because in those early days of 10 years ago, initially we are supposed to achieve cytogenetic response, then we say we need to achieve MMR, and now only we say we need to achieve CMR. So, but I think treatments will gradually get better and better. I have started doing hematology in in the early 90s, 92. We used to see patients leave us after 3 years of CML, and that is the reality. After 2-3 years, our patients leave us. We don't get to see them anymore. But nowadays we have patients, living 10 years, 12 years, and still looking healthy like you all. So I think that is already the first step.